the next day, on Monday, he came to me and said, well, I've talked to my locum, Helmut Fischer, also a fantastic surgeon, that you should also start to learn rhinoplasty. And I was only 1.5 to 2 years in the department. This was absolutely new. No one else before at this age was allowed to do rhinoplasty.
Ladies and gentlemen, welcome to another episode of the Rhinoplasty podcast with me, Dr. Cameron McIntosh. So we are into the month of May, and our special topic for the month is rhinoplasty experts, and it's brought to us by Karl Storz. I think it's actually pretty cool that Karl Storz are bringing us our first guest for the month as well, all the way from Germany. Somebody who's been very undercover for many years, but what a nice chap, eh? Sebastian Haack, thank you so much for being on the show today.
Okay, thanks for the invitation.
So, great. Sebastian, I mean, it was so good to see you a few days ago in Bergamo. Yeah. There's lots I want to chat to you about, but let's kick it off with this question. Tell us your journey from starting, possibly even wanting to become a doctor, and eventually filling in some huge boots in Prof Wolfgang Gubisch's boots. Where you're at now? I'm fascinated to know how that happened in your life.
Yeah, it really started a little bit weird because my grandpa and my dad used to be also medical doctors, and they run their own business. They had a private practice in Stuttgart, my hometown, and they were orthopedic surgeons. And during my university time, I did a lot of work in the big trauma hospital as a student. You could help there in the UR, do some jobs on board. So at the beginning, I was pretty much focused on the traumatology aspect of surgery. And for some reasons, my dad was moving to political aspects of medicine. He became the head of the association for the surgeons that are running own practices all over Germany. So he really left his practice earlier than I could take over. So and he didn't want to keep it longer, so it didn't fit in his plans. And then I said, well, so now I'm free. And then once I quit my work for the traumatology department in Tübingen, because there was a quite good travel always there, and it was not that practical. So I looked for another way to have a little bit of job next to university, and then I found a private practice where Wolfgang Gubisch was doing his private work, because once a week he was out of the hospital doing his cosmetic work. He also did in the rest of the days, but there was a special deal. They had really good conditions, and like working in a private setting is more effective than in a general, let's say, state or municipal hospital. So there I got him to know, and then I said, well, let's try plastic surgery. And then the last year of training in med school is purely on ward, purely joining the doctors on ward and surgeries, so practical hands-on. And it's split in 3/3 in Germany, and one is internal medicine, one is surgery, and one you can choose. And I choose plastic surgery as a field of selection. And 8 weeks was spent in the general plastics, where they did hand and breast and all this. And the other 8 was in the facial plastic department that at this time was run by Wolfgang Gubisch. And there I get to know him. And then after my training in med school was finished and I did my exams, I applied for a position as a young resident. In Germany, this is not centralized, so you have to apply on each and every department separately. And I didn't thought so much of getting the job because at this time Wolfgang wanted to have residents that had more training already, or were far on in their training period. Plastic surgery 6 years in Germany, so we wanted more to have like colleagues in the 4th, 5th, and 6th year. But he said once, okay, let's try this guy, and this is how it started. And then first I got a 2 years contract, and he said, okay, you do a good job, And at this time it was really old school, like the boss is calling Saturday evening. On Monday, I need a presentation with 20 new cases of extracorporeal septoplasty. Let's do it. And then, okay, of course you had to do, at this time, most of the photos were just put on dias, like on paper, and then you had to digitalize it with special systems and all. I think thousands of pictures I digitalized, and it worked. I mean, I supported his scientific work and all this lecturing, and he said, well, you do a good job. And so I went on, and then the good thing was, at this time, only board certified plastic surgeons in this department were allowed to do rhinoplasty. So only the ones that are pretty old. But it happened that after 1.5 to 2 years, there was a big celebration of 60 years plastic surgery in Marine Hospital, at the Marine Hospital Stuttgart. It's the oldest plastic surgical department in Germany. And it was a big celebration party. And there I was allowed to give a talk. And I was shivering, nervous, like as a really young resident, and lots of honorary persons have been there. Obviously he and a lot of the other colleagues were quite satisfied or okay with my presentation, with my talk, and especially the widow of the founder of the department was there. So who founded the department in 1940s somewhat, and she really appreciated my talk. And so this was the beginning, when the next day, on Monday, he came to me and said, well, I've talked to my locum, Helmut Fischer, also a fantastic surgeon, that you should also start to learn rhinoplasty. And I was only 1.5 to 2 years in the department. This was absolutely new. No one else before at this age was allowed to do rhinoplasty. So this was, and basically that was the kickoff. I mean,
yes, that's so exciting. So to be able to have that honor. Okay, so now you're starting your residency, and you're getting into kind of being groomed already. But there's still many years to go before you become the head of the department, as I understand it.
Yeah, and then of course there are different steps you have to really take. I mean, first then I had to leave the department for 2.5, 3 years to do all the other plastic stuff, breast and hands and burns, intensive care. But then I came back. He said, well, I like you back. And then I came back. And then I did my board certification working in this department. And this is always a new step, because then generally your contract ends in the hospital. Normally you get a contract in Germany, like let's say the first 2 years, they check if they like you. And then if they say, well, it's fine, then you get the next contract is one for achieving your board certification. So then this was the next step. And then as he said, well, but I like to keep you, stay in my department. And then I got half year later, 9 months later, after my board certification, I got I climbed a new step in the pyramid, which is from a resident to a senior surgeon, which is called in Germany Oberarzt. So it's normal Assistenzarzt, assistant doctor, and then the senior. And then another 2 years later, his locum, Helmut Fischer, stepped a little bit back. He reduced his, from 100% work, he reduced to 70% work because he had some medical issues. And then I became the locum of Wolfgang. And this I had been for another 1.5 years. And then the funny thing started, because then I was pretty young. I mean, at this age, I was 37. And then it was not clear that I will be the next head of the department. There have been some more senior colleagues that they were in the race, let's say like this. But then there started a really funny thing. I got the offer to create a new facial plastic department to build up in another hospital. And I really know it like yesterday. Then I phoned Wolfgang, at this time still Professor Gubisch. I phoned him and I said, well, I have to talk to him. It's concerning our future, and if he has time. And then he was coming back with train from a meeting, and then I really picked him up from the main train station, and we went to a cafe, and we sat down for I think 3 hours or something. Had a coffee and croissants and all this, and we were talking, because then I said, well, the idea is I build up a new department, and he should be the senior head, the senior professor of the department. So we should do something together, because he always told me when he will leave, we will do something together, because even at this time we had a good relationship. And I said, well, now we have the chance, we can build up a new department. So what would you think? Let's go there. And then he was thinking, and we're having perhaps some sparkling wine, or I don't know what it was exactly. And then he came up with the idea and said, but wait, when we are about to create a new department elsewhere, why not doing this in the existing department? You become the head, and I will be still there for some years as the senior professor, as the senior surgeon. I said, yeah, why not? Why changing the building? Why changing the setting? And then we went to the CEO of the hospital and said, well, there's an idea from us. What do you think? And then, like normally the hospitals don't like so much making or getting the new head out of the department. They like to have to get fresh blood from extern. But since we were doing pretty specific things, like it's a facial plastic department run by plastic surgeons, and we're really focusing only on the face. We're only doing noses, ears, skin cancer, some aesthetics, and we're doing what perhaps not all do know. We're doing a pretty good number and good job in nasal reconstruction as well. I think we are one of the biggest departments in terms of numbers who are doing complete full nasal reconstruction. And there's not so many people who can cover the whole content, because it really comes from the genes of this department. You really have to be there to fill all these tasks. And then the CEO also was a child of the hospital. He really made his way through all the different layers, different steps, stairways in the hospital. So he also said, well, it's basically my history as well. I started as a young colleague, and then I became CEO of the department. So let's try this, and this is how it happens. And so it's now 7 years. It's 7 years now that I'm head of it with 38. I mean, this was pretty young, but it works, and it worked because we are so focused. I mean, really, I really got this with the mother milk. From the beginning, I was trained with the content of the department. If I
the mother milk and the cream has risen to the top, eh? So, but Sebastian, it's funny. It's you think it's so young, it's state free, but the weird thing is, like, I'm 46 this year. It's now we're mid-age now. We are, as much as we looked up. I mean, look at like Wolfgang, what he did. Yeah. But when he was your age, he was doing what you're doing as well. Yeah. So the question that I wanted to ask you next is, how have you managed a family life in this massive stress of being the head of a big plastics department in Germany? Because your kids are similar age to mine. How do you get that balance right?
Actually, to be honest, I'm not sure if I do get the balance right. This is the wound point, right? I mean, you really hit the knife in the wound. And of course, they're running such a department, and I really follow Wolfgang's step. As you know, I travel quite a lot and give talks and around the world and do lecturing and so on. Of course, it limits the family time. I mean, there's no time no way to deny that. And of course, you have to have a wife that supports that. Otherwise, there's no chance to get the things run. I mean, I really try. I mean, this is sometimes a little bit perhaps overused, but I think it's not completely wrong. The expression quality time. I mean, if in case when I'm at home, I really try to do things with the kids. We try to go out. We try to be in nature. I really try to be with them, and we try to talk. I mean, it's so important to not to lose conversation to miss conversation with the kids. It's always so important to have contacts and just to talk. And luckily, I have three girls, and girls like to talk a little bit more, I think. So it's okay. And sometimes I feel almost that it is a little bit unfair for my wife, because sometimes it's like she has all to fight the daily fights at home, and I come home at night late or in the evening later, and then I just go to the girls and to one of the girls, and I ask, how was your day? And then she starts telling me her day. And then I later come down to my wife and say, well, did you hear this and that happened to her? And she says, no, she didn't tell me. So sometimes I feel a little bit, that it's unfair. But yeah. Oh, on the other hand, it's good to have still contact and to do conversation. This is the most important point. And we try to get to celebrate good holidays, because this is really the same. I have in my memories, when I think of my father, he was also a hardworking man, and we did under the week we didn't have so much together, but we always had great holidays, and I remember always these holidays.
Oh, that's cool, man. Okay, so tell me a bit more, or the listeners really from all over the world, about the Stuttgart Rhinoplasty course.
The course, the Stuttgart Rhinoplasty course. Yeah, I mean, fortunately, the rhinoplasty course will start next week. This is really unbelievable. It's the 29th International Rhinoplasty course. It's so next year we will have a jubilee course. It will be the 30th. So this is a fantastic course, and we once again, we are fully booked this year. Wolfgang also will be there. He won't do surgery, but he will do moderation, will give talks, and lets us participate on his huge experience. I invited some other colleagues who also will do live surgery. We'll have 8 surgeries. We will have 3 secondaries, 5 primaries. And I think at least in 2 cases we will need rib cartilage grafts.
So for For the listeners on the podcast who are not familiar with the Stuttgart course, just give us a summary of why somebody should come and attend it.
Really, the Stuttgart rhinoplasty course is really focusing on live surgery and all the tricks and little tricks and things that you most probably will not see within styled video where all the little things are cut out. So it's really about how do you do your infiltration, what are the incisions exactly like, and where do you struggle, where you can see where's the surgeon having his issues, and all these little tips and tricks. And this I learned really from Wolfgang. We don't hide anything, and we're completely open. We always have our microphone. Everybody is free to ask. We answer everything. We don't hide anything. So the main thing is really live surgery. We have, after now 29 years experience, I think we have an extremely good, camera setting, light setting. So we really know how to get the best camera quality. It's HD quality. We are focusing on the quality of transmission, so that really the colleagues really feel there as they would assist you or even see more, because sometimes the resident or the assistant doesn't see so much because there has to be some precision. So we played many years, we tried many different variations on how the light setting, camera setting, and I think now we have a quite good setting. And in the evening and on the first day we will have our lectures. That of course this year, as it should be different, we also focusing on dorsal preservation techniques, and so we will have on Wednesday afternoon we will have our first part of lecture, which will only deal with dorsum techniques. We will have an interesting panel because also Göksel from Istanbul will be there, Milos Kovacic from Hamburg, Frank Riedel from Mannheim. So we have a lot of national, international colleagues. They have different approaches, different experiences, and we really like also we'll only do straightforward lectures. We also will do panels. We will discuss, because I think following experienced colleagues discussing points, and I wrote today some really provocative questions to my panelists to really get on the point, because sometimes you see the extremely smooth designed lectures, and it's not always that easy, right? As we all know, there's not the one and single way, and this is what my message should be, is taking care about little details. You must know about the details. You must know where are problems, difficulties of each and every technique, and this we like to discuss. It's not, I'm not sure if people that have heard my lectures, I mean, I think, I hope I can transport it, or I hope it comes clear. I'm not I don't sell one and only things. I mean, it's really, and sometimes this is one little critic of our rhinoplastic colleagues. Sometimes some people are really a little bit too much into selling the only truth, and as we all know, there's not the one truth, and this we will show in our course, and this is why I think the people coming, basically from all over the world, from Australia, from Brazil, from South Africa, and joining, because it's not a course that is only focusing on one special technique and is promoting that. So we are covering most of the current techniques. So it will be interesting.
And it's open to only plastic surgeons, or
no.
ENT surgeons as well?
No. Yes, of course, everybody can apply. Most of them, of course, are ENT and plastics. We have some MaxFax colleagues as well. And this year, the 29th course, in 20 we had to cancel because of the at this time new Corona pandemic. Then in 21, we made it pure online, which basically was a good success. We had I think we had 240 participants, which was quite okay. And this year we will make it hybrid. So we will have 120, which is our maximum on-site. And then last week we advertised and promoted our online opportunity to join the course. So everybody who is not able to come, for some people due to vaccination issues, travel issues, it's so good to have it also online. And we will have a 1 month on-demand possibility. So if you join online, you will get not really edited, but somehow a little bit edited videos that you can look for one month from a cloud, basically.
Now that's awesome. Nothing beats being in theater next to somebody watching them do an operation, because, like you say, it can be these beautiful results that you see at a meeting, but that's not what's happening on the table. So, touching on this, I just want to ask your opinion on the self-promotion in social media for rhinoplasty. How do you get that balance right? Because there's so many people out there who are trying to add good value and showing real results, but then you've got the guys who are not doing it correctly.
Yeah. I mean, this is an extremely hot topic, Cameron. This is an extremely hot topic, and I'm a little bit, let's say, anxious about where the future will head to. We have basically 3 different ways how the patient will find us. One is colleague referral. This is really one extremely important way how the patient finds you. The other is witnesses of operated patients. Like a young lady comes and says, "You operated my colleague, my sister, my aunt, somewhat, and I like the results, so now I like to come to you." And then the third pillar, more and more, is the social media stuff. And especially for young colleagues, this is one where they really like to speed up the way of being popular in the public opinion. And okay, I understand. I mean, especially if you run your own business, you really have your costs. You really have to find your patients. And I mean, I think I don't really say I don't like it. I also have a little Instagram account, so it's running on a really baseline. But of course, you get attention, and you can. It's helpful. But I really think it's the way how you do it, as always. I mean, for me as a medical colleague, I don't like on my professional Insta account, I don't like to post photos from me on holidays, for example, or I don't want my kids posted. So I think I only post professional things, and so I keep it quite basic on professional aspects. And this is one thing, but this is a matter of taste. And I know colleagues, they don't have an Instagram account. They don't do anything like this, and they're extremely successful. They have extremely good patients. So it is not urgently necessary. You can have success without this. This is for sure. When you like to do it, okay, do it. The only thing where I really get a little bit angry is when I do see patient colleagues, let's say they manipulate their results. For example, in Germany, we are not allowed to show pre and post in comparison. We are not. I'm not sure what is it like in South Africa, but we are not allowed. Okay,
no,
we are not allowed. Yeah. So it all has.
We are allowed to show it in South Africa.
So what I do do think is if you can be active, you can make a show. It's fine, but you should be honest. This is the only thing I really would ask everybody to be. I mean, I don't really think of like changing pictures like in a simulation program. I'm not sure if people doing this. I don't know. Perhaps, I don't know. But what I do know, I know colleagues, and I don't say a name now, but everybody could see it. They manipulate how they take pictures of patients. You know, like we all know about the fisheye effect. Coming close with a camera, everything looks wide and bulky and thick. And when the patient comes to the follow-up, he steps 2 meters back, zooms a little bit in with a tele lens, and then all of a sudden you see really the eyes get closer, everything gets smaller and neater and nicer. Not only the nose, but everything. And then it's shown because I had a patient that had a big nose, and she told me, "Can you make it smaller?" And I said, "Well, we can transfer it into a better shaped nose. You will get a more elegant nose. You will get a less obvious nose, but we can't make it smaller because she had so much soft tissues that couldn't be removed." And then he said, "Well, but this colleague, how's he doing? He's showing these pictures." And then I said, "Well, let's show me the pictures." And then I saw what he was doing. And then I talked with other colleagues, and they all knew that this guy is doing this kind of advertisement. And this I don't can accept, really. I mean, really, this is for me, it's not okay. But I think what I learned from Wolfgang, this is really one Stuttgart school point is work hard, take care about your patients, try always to get the best result, what you can get in the moment, and then later the success will come because the patient will appreciate what you work. And then it's the advertisement thing is not, then it is not this important anymore. I hope it will. Let's talk about this in 20 years. But I hope it will. It will be, even in 20 years, it will be like this.
Okay, so I have another completely different question on behalf of the listeners. What on earth is TTC? Please explain that to us. Yeah. How did this thing happen? When was that moment, and what is TTC, and why should we know about this in rhinoplasty?
Yeah. TTC is the abbreviation for transcutaneous transosseous cerclage suture. In these days, we are using this method for many reasons, for many aspects, but originally it came from extracorporeal septoplasty. Because one hard piece of the department, and even of my work today, this I learned from Wolfgang, is the septum. So it's really as the central pillar of the nose. And one of his techniques that made him extremely well-known and successful is the extracorporeal septoplasty. So in severely deviated septums, when the dorsal leading edge is far out of midline, or you have broken septums under the roof, it's sometimes really helpful to take out the whole septum, release all the tensions, all the memory effects, and create a new and straight septum, and then replant it, and then fix it without tension in the new desired position. And then there are 3 positions of fixation important. Of course, it's on the maxilla, on the ANS, if it's there, or at least in the maxilla, but favorably on the ANS. It's in the cartilaginous vault, but the best would be to fix it in the bony part. So then the L is completely strongly fixed. And the fixing at the bony part, especially when the bones are not long, is tricky. How to fix it in the bony part up there. And there is where the TTC suture come in place, because this was always the weakness of the technique, that there was a fixation high up to the central keystone where you could suture still through the upper laterals, next to the bone, but not in the bone directly. And this is why I developed the TTC suture to fix it really bony wise. And this is then you place your septum in. It's placed into the bony side walls. You really look that it's good aligned, and then you fix it temporarily with a cannula through the cartilage, and then you drill with a number 1 needle. It's a 20 gauge needle through the bone, the new septum, the other bone, and then you bring in a suture, pulling out sutures running through everything. You lift up the skin, bring the sutures down, and then you can tighten a knot. And then you have a cerclage here where the septum is, we hope, forever hung up tightly. And of course, we modified, this was the original technique, doing a vertical cerclage that has been published in PRS. And then, but then we modified it a little bit to make 2 passes and making it horizontal, because then you can still shave with the burr, with the diamond burr, with the piezo, the dorsum. If there's would be a suture, you would of course tear off the suture with the burr. But if the suture is running like 1.5 millimeters down the dorsal leading edge, just horizontally going around, then the dorsum is completely free, and you can shave and you can modulate still on the bones. Until you pinch everything together or fix it together, it's stable. So it's really, you can use a burr because it's not free floating. This is the great advantage. So
no, it's an awesome thing. So what made you? When did you come up with this idea of actually attaching it to a drill? Because you must have surely been using your fingers the first few times and thinking, this is hard work to get through the bones.
And this is where it come from. We try to use it with the fingers, and there might be brittle, thin bones in some ladies where it's easy with the fingers. But for me and for most of the colleagues, it was too hard to drill. It really, after 10 minutes, you really lose your mood to do this, and then you don't use it. So, and then at the beginning, we tried a lot of things. And then funnily, it happened that we have a cylindric burr. And the cylindric burr fits perfectly in the conus of the needle. And with this, we could move the needle. And this works. This worked and works. But there's a but. I feared that there is a little bit of plastic dust, like when the cylindric burr is having little movements in the conus. So this is why we created a pretty cheap device, which is a DIN-normed Luer-lock adapter that can put in every handpiece, drill handpiece, and this can host the needle, and then there won't be any plastic dust that has been scratched off from the inner side of the plastic conus of the cannula. And this is the story. And we have good contact.
No, it's very cool. I love it.
We have a good contact to a German company where we do some development of instruments, and we had a good already existing good contact, so it was easy for us to get this little adapter produced.
That's cool. That's cool. Okay. So, Sebastian, it's so interesting chatting to you. I've got one more topic I want to chat to you a little bit about, and this is preservation rhinoplasty. It was so interesting being in this Bergamo course, and I took 2 weeks now to travel around the world and spend time with who I think are very influential rhinoplasty guys to really test this preservation thing out. And, my feeling is I think there's some really important parts to it. I think, if anything, it's told us to just kind of respect the nose again. Don't just the nose is so complex, and the new kind of anatomy that Peter Polhazy and them are showing us, etc. It's an important thing just to where we've just kind of gone in. However, at the same time, I don't think that it is the answer to rhinoplasty. I think there are many ways of being able to achieve a good result in rhinoplasty. But I'm very interested to hear what some of your thoughts are around preservation rhinoplasty.
Yeah, so first we have to really clarify on which part of preservation we are talking? I mean, because it really turned up that preservation at the beginning was a pretty mix up of basically everything. There were the surface techniques from Ishida and Ferreira. There was the classical Kotl. There is dorsal techniques of Saban, or they have been much older. They have been already described in the 1915 and so on. It's old techniques. So, and that is dealing with the dorsum. Then we have the preservation aspect of ligament preservation for the tip. I think you most probably were asking for the dorsal preservation. I think because this is still
within the soft tissues, the tip, the ligaments, the whole thing. I mean, preservation is such a huge topic to talk about, but it's really some of your mullings over what 20 years or so of being around rhinoplasty. Maybe we can focus more on the dorsal preservation side of things. But I'm just interested to know what Sebastian Haack thinks about this whole preservation wave that's hit rhinoplasty.
Yeah, you explained it correctly. I mean, it's a wave, but after every wave, there will be things remain, and really. I do dorsal preservation, rhinoplasty. I love it, but there's a new aspect now, and this is finding the right indication. You know, I had an extremely interesting conversation with a really nice colleague, Miguel Ferreira, who's doing these surface techniques, and he really said, you know, in former times with structural reconstructive rhinoplasty, we were not talking so much about indications. I mean, for the dorsal technique, we just did. We did some hump removal and then we reconstructed spread or flaps, spread or grafts, and perhaps at the end camouflaging. And with this technique, you can basically deal with every single rhinoplasty. You can deal with secondaries, you can deal with primaries, you can deal high radics, low radics. If you follow this principle, you can operate on each and every case. And this is why it has been for many years the standard technique. This is how I feel. Why did this technique came up so much and the other techniques didn't succeed so much? But there's a but. Always there's a but. And the thing is really we all have issues or had issues with the dorsum. I mean, when I look, we published a retrospective analysis of our secondary cases that we had to operate on, and we found that the most often reason for revisions in our own cases was irregularities of the dorsum. I mean, not big things, not like you have to do everything new but little things. So, of course, there has been an issue, obviously. So, if there's a technique that gives you more security or less revision or more satisfaction on the dorsum, why not trying it? Then we have the technique that is not new, but it has now been revisited or has been brought up by some clever guys and also guys that are like Barish, that are extremely technical, good. And he's a clever thinker. I really love him. When they had good support by Roland Daniel, who was like the scientific motor of all of this. It's worthwhile. But now the next point comes, and this is indication. And now we have to talk about indications because, and we have to talk also once again, like I said, what we will show in our course about little tricks and the little details, because it's not an easy surgery. It's not one thing that solves all your problems. It's not one that is free from complication. So, and now people that are extending the indications, they often combine it with a lot of things. I mean, it's not just putting the hump down and then it's fine. They make little cuts there, burrs there, little drills there. So it's not that easy. So we have to talk about indications. And today I really totally agree. I had the discussion. I had the chance to sit with next to Dean Toriumi in the gala dinner in in Bergamo. And he started also dorsal preservation. And we found that we have the same impression that there are cases in these days where in former times, I really felt sorry to take the dorsum apart. Just 1.5 millimeter hump, nice dorsum. And in former times, you really thought, oh, why do I have this to take apart? Why applying spreader rafts? Why spreader flaps? And then it's to over resect it and have to raise it a little bit with diced cartilage or with fascia or a burrito DCF. So, and these are the cases where I love to do dorsal preservation. And we had the same. He also he confessed that he also now has cases in these days where he would think where he has pain, inside pain when he would have to take the dorsum apart. And if these are the patient that is sitting in front of you, then it's the perfect indication for dorsal preservation. And then you should do. The question is, and this is the problem for beginners. How should they start? And it's so confusing. Now I think when you now go on the Bergamo meeting with all the different little aspects and techniques, much more variations than 6-7 years ago, I think it must be extremely difficult for beginners to find the right way. I think it's really, really hard in these days. Really hard. What do you think?
No, I agree that I was so lucky. I spent a week with Dean in Chicago a week ago. It was to watch him operate. There were 6 cases and sit there and understand. It was excellent. It's fascinating.
How many preservations?
Sebastian, I've so enjoyed talking to you. It's been one of the best interviews I've had on the Rhinoplasty podcast. It's so interesting just to hear where you're at and what you're doing. And so thank you very much. And guys, listen, I need to say, if you haven't done the Stuttgart Rhinoplasty course, you haven't done the Rhinoplasty course yet. So make sure you do it. It's fascinating. These guys, there's not many guys who've been in the game for 29 years. So sure. So thank you. On behalf of all the listeners, I just want to say thank you very much. And Carl Storz, thanks for enabling this month of May with Rhinoplasty Experts. And Sebastian, I appreciate you taking time off from your family. Make sure you say hello to your wife first before you say hello to your daughters. And all the very best from all the listeners from around the world. We really appreciate what you're doing for rhinoplasty globally.
Okay. Thank you so much. It was great fun. Thanks for having me. I enjoyed it very much. And the 1 hour, basically, we almost talked 1 hour, really flew by, at least to my feelings. And really, Cameron, I hope to see you in a few weeks, few months. It shouldn't be too long, right? That we should meet.
No, hopefully very soon.